Hello guys, and welcome to this CPG upskilling session on paediatrics. It's more of a recap. For some of you guys, there'll be some new stuff on this, just talking about a number of issues to do with peds, because they're not a cohort of patients that we get that often, and when we do, they can be quite sick. Some of the stuff we're going to have a bit of a chat about here. We're going to talk about the just a quick revision on primary secondary survey, having a quick look at the new CPG, the physiological differences of children, because children are just, anybody under 15 years or under is a child, but there's probably about 6 or 7 different physiological patients within that cohort. We'll have a chat about that. Pediatric assessment triangle, which is something that's probably underutilized. I use it in its adult form and it works quite well. Recap on primary and secondary survey, and just having a look at age appropriate assessment techniques, because different age children will have different approaches just to keep them calm. So let's have a look. So children, they're not just small adults. Some people think, they're just a little bit smaller, we maybe need to use smaller equipment, but that's not the case. They're completely different altogether. They have different abilities to comprehend, different vocal and verbal abilities. Some are pre-verbal, some are paraverbal, some are, have the same level of linguistic ability as ourselves. Some of them get quite upset when they're separated from their parents or caregivers. Some of them don't mind. Vital organs themselves are not as protected as they are in adults, and again, age appropriate depending on. Some of the vital organs like the spleen and the liver are not protected by the ribs, because the ribs are a little bit higher up. Blood volume is about 70 to 80 mils per kilo, which is quite low. So I consider them almost like a sports car. So they have far less going on, but it can go an awful lot faster. So they don't have the same blood volume as us, but it can be circulated far faster to facilitate perfusion. So their heart rates are quicker, their respiratory rates are quicker, their metabolic rates at cellular level are far quicker. So they have an intrinsic hunger for fuel and oxygen all the time. Compensate better than adults, and they maintain blood pressure until they're seriously critically ill. The reason for this: everything is brand new and out of the box. So the speed of their heart, their pump speed can go up to 200 beats per minute, and it doesn't cost them a thing. Their muscles of respiration, they can ventilate at huge rates, which we would struggle big time at, and they can do this for long periods of time until they run out of fuel, and then they crash. So we need to be very mindful in our assessment of children. They can maybe present so that they don't look critically ill, but unless we're aware of the subtleties of how they're presenting, they may very well be pre-arrest. Depending on age, they may not have a large antibody database. So a 6-month-old child does not have the same number of antibodies as a 5-year-old, because they have not been exposed to the same number of pathogens and gotten sick and gotten over it. So it predisposes them to infection. Young children are going to get sore throats, runny noses, ear infections. This is common. As they meet pathogens for the first time, they get sick. They build up a database of antibodies so that they can fight the same infection again. Depending on age, the cranial fontanelles may not be sutured, so there may be a little bit of movement in the bones in the front of the skull here. In small children, the airways are quite funnel shaped. They actually are very, very narrow and very easily blocked. The head is disproportionately larger than adults. Again, they've got quite a large occipitus. Again, because they're head heavy, and the muscles of, in small children, their leg muscles and their balance is not great, they're predisposed to falling, and the area that can get injured quite frequently is the head, because it's so heavy. Pediatric assessment challenges, there's loads of them. So you'll face different challenges and difficulties with different age cohorts. So each age group have variations in their physical, emotional and intellectual abilities to actually interact with you. It's important to have a knowledge of age-specific development and the physical signs and the vital signs associated with that age group. This will help you decide what's normal or abnormal, because if we don't know what's normal, then we don't know what's abnormal and what's a problem. So you must always gain consent from parents or guardians, and this is really, really important. Here we have the CPG itself. There's nothing weird, funky or wonderful in it. It's quite easy it's a nice little flow. It's a pretty linear flow. There's not an awful lot on it. There's a couple of nice information boxes on it, which we'll have a bit of a look at. Okay. So here we are, the 2017 versus the 2021 CPGs. So again, primary survey PED equal to or less than 15. So if there's child protection concerns are present, report findings as per the Children First guidelines to the ED staff. That's your 2017 guideline there. And this particular one, if child protection concerns are present, report findings as per Children's First Act 2015 to ED staff and TUSLA in a confidential manner. It's similar but a little bit different, so the subtleties are a little bit different. Here we are, here's the top part of the actual of the algorithm itself. So if it's a medical issue, we're going to take in standard infection controls, which we are. And again, we mentioned kiddies are very predisposed to infections, particularly young children, because they haven't got that antibody database built up, because they haven't been exposed to tons and tons of pathogens. So we have some nice information boxes around here that we'll have a look at in a moment. Consider pre-arrival information. Yeah, absolutely, always consider pre-arrival information. Scene safety survey and situation, that's fine. The PAT, so the Paediatric Assessment Triangle, is the first thing we're always looking for. This gives us our first view from the door. So, you know, how do they look? How do children normally look? If we're talking about young children, for instance, under 5, they're busy. They're running around, they're wrecking the house. You know, they're always busy, always into everything. They're explorers. So if that child is sitting there and they're not running around, they're sitting there, they're quiet, they're saying nothing, they're not moving around, then their appearance will actually be altered. And here we have the Paediatric Assessment Triangle here. Appearance, work of breathing, circulation to the skin. If their work of breathing is increased, we can quickly see it from the doorway. And again, if their circulation to the skin, if their skin colour is off, then we know that they're hypoperfusion. Again, this is done from the doorway, and we'll talk about this in a moment, because it allows children time to kind of get used to ourselves being in their world, which they don't tend to like strangers. So head tilt chin lift, if the airway is patent and protected. If it's not, we're going to open the airway with a head tilt chin lift. This again is a medical issue. This is not a trauma patient. If the airway is patent and protected, then we're just going to move on down to assessing ventilation to see if it's adequate or not. Underneath here, we're talking about circulation. So pulse less than 60, we're into pediatric CPR. And again, on one of the other sessions, we're going to have a bit of a chat on one of the pregnancy sessions, particularly about neonates and neonate resuscitation. Again, heart rate under 60, signs of poor perfusion, yes. Life-threatening, will go to the appropriate CPG and activate ALS. If no, then we're doing an AVPU assessment, making our clinical status decision. It's going to be non-serious or life threat, serious life threat, or life-threatening. Life threat, serious, not life threat, we ask for ALS. We'll always err on the side of caution. Non-serious or life threat, we'll move on to the secondary survey. So it's a pretty straightforward algorithm to follow, guys. The assessment tools here, they are kind of blown up a little bit. So we have our estimated weight for a neonate at 3.5 kilos. Our 6-month-old is 6 kilos. 1 to 5, age by 2 plus 8, and over that is age by 3 plus 7. That's pretty standard, that's as per. Normal ranges, so there's some nice ranges here. 0 to 3 months, we've pulse and respiration rates. There's some differences to the last one. Either, these are here, so they need to be kind of looked at. These are given as age appropriate norms. So if we're finding stuff outside of these ranges, we can consider it abnormal and our concerns can be raised. Paediatric Assessment Triangle, again, it's given a significantly decent sized box, because for me, this is probably the most important thing. When I walk to the door, this is going to set the alarm bells off or not. So the PAT, an observational assessment from the door. And the reason why we do it from the door is, when we start immediately wandering into a young child's world, they will get upset. They don't like strangers in their world, particularly children under the age of 5 and 6. Having a look from the door, if we walk in and intrude in their space and upset them, they will get upset very quickly. They will cry, their face will go red, everything changes. So our ability to actually measure the Paediatric Assessment Triangle values then goes out the window. So hanging on from the door for a couple of minutes and just observing from a distance allows us to get a feel for how they are. Yeah. So it formalizes a general impression. Identifies general physiological abnormalities. So if they're struggling, if they're, as we said, young children are busy. If they're sitting there lethargic and they're not moving around, their appearance has changed. It's altered. It's altered from the norm. We'll then have a look at their work of breathing. So if their work of breathing is increased, we should spot it pretty handy. Some of the stuff we'll be looking at here will be nasal flaring. We'll be looking at tracheal tug. We'll be looking at subcostal or substernal retractions. And we have a couple of videos that we're going to have a look at with that. Remember, kiddies will do well compensating, and they'll shift huge volumes of air without looking particularly stressed with it. And they'll do that for a long time until they eventually stop compensating and crash. So we need to spot the early signs of respiratory failure before bad things happen. We then have a look at circulation to the skin. Circulation to the skin, again, if the skin colour is off, I'm concerned. I'm not concerned by any one part of the paediatric assessment triangle. If their appearance is off and their work of breathing is not increased and their circulation to the skin is okay, that's fine. If I see their appearance is off and I see circulation to the skin is off, then they're ticking two parts of the triangle, I'm concerned. Any more than one part of the paediatric assessment triangle that raises note to me causes concern. That child needs to be kind of travelling. That child is pretty sick. And that's the general rule of thumb that I use. So, appearance, work of breathing and circulation to the skin. So, appearance, abnormal tone, so they're flaccid. Normally kiddies are full of muscle tone and flying around the place. Interactiveness, they're busy. They're very inquisitive. They're explorers. Consolability, if they're crying and they're sitting with a parent or a caregiver, can they console them? If they can't, what's going on? Abnormal look or gaze, they're just not really in this world. Yeah. Abnormal speech or cry. These are things that should set the alarm bells off. Work of breathing, so abnormal sounds, so grunting or striders or wheezes, anything that's not quiet, anything that's abnormal. Abnormal positioning, so they're sitting up straight, using accessory muscles to help them breathe. Retractions, nasal flaring, I've mentioned already. Circulation to the skin, so pallor, so they're pale, mottling, or cyanosis. One of these on their own, the child is a little off. More than one of these, two or more of these, and this child is seriously ill. And that's the rule of thumb that I would be using. Sick, not sick, or not sure. Always err on the side of caution. Paediatric assessment triangle, so the PAD identifies the child in one of the following physiological categories, so stable, respiratory distress, respiratory failure, shock or hypoperfusion, where cells are now no longer being fed fuel and oxygen appropriately, central nervous system metabolic disorder, or cardiopulmonary failure or arrest. And it's pretty easy to spot these things, guys, okay? So the core dilemma, so sick, not sick, or not sure. This child here, are they sick? This little kid here is very sick. Substernal retractions, nasal flaring. This child here is playing with this paramedic guy, and he's quite happy exploring and having a look, so he's not sick. This guy here, looks like he's been caught with his hands in the sweet jar, but he's sitting upright. He's quite thin, and he's got some pallor on his skin. This child here is obviously quite ill, and you don't need a degree in medicine to really see how ill this little child here is. So, the challenge of paediatric assessment, so PEDS, they go from 0, from birth to 15, allegedly. There's a huge variation in physical, cognitive, emotional, speech. There's huge variation in everything. Sometimes, a couple of months will make a massive difference, sometimes a couple of years. Distinguishing normal from abnormal requires age-specific knowledge, and there's some stuff here on the CPG that you should be having a look at. So pulse rates in 3 months old, vary up to 180 beats per minute. And then, when you're looking at kiddies, 7 or greater, it's more towards normal trends, 60 to 90, So there's massive differential here within a couple of years. Respiration rates, up to 3 months, 30 to 60 respirations per minute, because the child has a huge demand for oxygen. That child is growing at an exponential rate, huge rate. They have a huge demand for fuel, a huge demand for oxygen. Those cells are dividing really, really quickly every couple of hours as they grow. Yeah. So the base metabolic rate in the cells in young children is that fast. They have a huge demand for fuel and oxygen. And remember, they don't have an enormous blood supply to carry this around. So the blood supply they have, the limited blood supply, gets circulated very, very quickly. And hence we have the high heart rates. Okay. So which of these patients is sick? And have a look and think about this. So we have a 2-week-old and a 10-year-old, and they both present in the same way. So a 2-week-old and a 10-year-old. So fever and less responsive. So would that be normal for a 2-week-old or a 10-year-old? Airway and breathing. So respiratory rate of 60 with an open patent airway, belly breathing, and an SpO2 that's unobtainable. Heart rate of 160, the skin is pink. Marble centrally, hands and feet are blue. Radial pulse is hard to palpate. So on AVPU, the eyes are open, no eye contact, no vocalization, and moves the extremities sporadically. So if you look in terms of a 2-week-old, that's actually all normal. All of this stuff is kind of normal. A little bit hot, a little bit warm, less responsive. You know, a respiratory rate is 60, patent airway, belly breathing. You can't get SpO2. Have a look. Have a look at the numbers here. 60. Circulation 160 beats per minute. That's kind of all in normal ranges. If you apply this to a 10-year-old, you know, they're way outside of the norms. So the 10-year-old is very sick, extremely sick, in fact, probably pre-arrest. The 2-week-old, this is normal. So this, depending on what age they are, they present as two completely different patients. A short video here to have a look at. And this particular video is talking about respiratory distress. So as opposed to anything else, this child is distressed. Doesn't really look it, but the child is quite distressed. So here we can see substernal, subcostal retractions. That child is working really, really hard to shift air, using a lot of muscle. It may not look an awful lot. If you could see the face, you'd see nasal flaring as well, which again would be very indicative of a child that's exhibiting air hunger. Okay. So with regards to this child, we're talking about this child is in respiratory distress. And to identify that early is a big thing, because what comes after the stress is, you know, pre-failure, and we need to be mindful of this. Let's have a look at this video.
We can look at a child from the doorway and recognize immediately that she is in respiratory distress. Work of breathing as an arm of the PAT standardizes our rapid respiratory assessment. To assess work of breathing, listen for abnormal airway sounds, and then observe the child for abnormal positioning, retractions, and nasal flaring. Abnormal airway sounds reflect problems in the upper or lower airway. Abnormalities in the upper airway may result in snoring or stridor. Snoring is a low-pitched sound most often caused by decrease of tone of structures in the upper airway, resulting in partial airway obstruction. Stridor is a high-pitched whistling sound. It is heard on inspiration or inspiration and expiration when there is partial obstruction of the trachea or vocal cords. Obstruction of the upper airway can occur with a variety of illnesses or injuries, including altered level of consciousness, loss of muscle tone, viral or bacterial infection, foreign body aspiration, or blunt trauma to the neck. Abnormalities in the lower airway can lead to grunting or wheezing. Grunting is heard when a child exhales against closed vocal cords. This is done reflexively to increase lung expansion and maximize gas exchange in the face of hypoxia. Grunting is heard most frequently in children with pneumonia, pulmonary contusion, or pulmonary edema. Wheezing is a high-pitched musical sound heard when air is forced through partially obstructed small airways in the lungs. Wheezing is most frequently heard during expiration. It may be heard during inspiration and expiration when obstruction is more severe. Asthma and bronchiolitis are common conditions associated with wheezing in childhood. Next, observe the child's position of comfort. A child who assumes the sniffing position has a severe upper airway obstruction and is attempting to maintain a patent airway. A child who refuses to lie down or leans forward in the tripod position is maximizing use of the accessory muscles of respiration. When retractions are present, the child is recruiting accessory muscle power to support ventilation. Retractions may be seen beneath, between, or above the ribs, above the clavicles, or beneath the sternum. They are more easily visualized in a child than an adult. Nasal flaring may be a tip-off to moderate to severe hypoxia. While any of these signs indicates abnormal work of breathing, The presence of multiple signs is associated with more severe respiratory compromise. For example, a child with audible wheezing, retractions, and nasal flaring is more worrisome than a child with wheezing alone. By combining appearance and work of breathing, we can further define the severity of illness or injury and determine the urgency of treatment. Consider a child who is alert and active, but who has retractions and nasal flaring. This child is in respiratory distress. Although she may require interventions in the field, she can be further evaluated before treatment is initiated. On the other hand, a child who has a normal appearance and increased work of breathing is in respiratory failure. Urgent intervention is needed to improve oxygenation and ventilation. Finally, a child with a history of increased work of breathing, who now has a normal appearance and decreased respiratory effort, is fatigued and is at risk for respiratory arrest. Assisted ventilation must be started immediately.
So, the visuals tend to work quite well. Talking about stuff is easy, but when you see the children struggling there, you see the retractions, the nasal flaring, you know, you can really see a sick child. You don't need loads of stuff on this. Respiratory failure. Let's have a look at this one. It's just a short one.
The third arm of the PAT looks specifically at the adequacy of perfusion by assessing circulation to the skin. When cardiac output is inadequate to meet metabolic demands, peripheral vessel constriction occurs. This shunts blood from the skin to the core, increasing circulation to the vital organs. Skin circulation gives information on the adequacy of core circulation. Key visual indicators of inadequate skin circulation are pallor, mottling, and cyanosis. These signs may be subtle. Pallor, or pale skin and mucous membranes, may be an early sign of compensated shock. Mottled skin with a patchy discoloration is another sign of poor skin perfusion. Cyanosis, or blue skin and mucous membranes, is often a late finding of respiratory failure or shock. The presence of cyanosis is always critical, but its absence does not ensure adequate oxygenation or perfusion. Never wait for cyanosis to initiate treatment. Once again, combining the assessment of skin circulation with appearance will help to determine the severity of illness or injury and the urgency of intervention. An alert, active child with peripheral cyanosis may simply be cold. A child with abnormal appearance and abnormal skin signs is in shock.
Okay. Hypoperfusion. Again, you've seen it in these children here. You know, once you're into signs of changes in skin color, you're into hypoperfusion. The child is in big trouble. Okay, so assessment itself. So the airway is patent and protected when we're actually assessing a child. So ABCs, is it patent and protected? Yes, continue to breathe. No, head, tilt, chin lift. Remember, this is a medical patient we're talking about. Is the breathing adequate? Again, this is tied intrinsically into our age-specific knowledge of the child. You know, a 2-week-old child breathing at 60 breaths per minute, that's no cause for concern. But if it's a 3 or 4-year-old child, it most certainly would be. So our age-specific knowledge is important. Okay, circulation, so pulse less than 60 and signs of poor perfusion. If they are, then we need to intervene, and pretty quickly. Okay, grand. Disability assessment, AVPU. Yep, so we do a normal AVPU assessment. We make our clinical status decision. It's serious, not life threat. Happy days. It's non-serious, non-life threat. So serious life threat, we activate ALS. Non-serious, non-life threat, we go to the secondary survey, which we're going to pop onto now. Okay. So the transport decision to stay or go. So indications for immediate on-scene treatment. Remember, these kids are not like adults. They're not going to, you know, if we're seeing signs of end organ perfusion, then we need to be intervening right now. So cardiac arrest, absolutely. Complete airway obstruction, absolutely. We need to intervene immediately. Decompensated shock. Impending newborn delivery. Status epilepticus, wheezing, stridor, or severe pain with a normal blood pressure. We need to be intervening with any of these things. Immediate transport and treatment en route. So an incomplete airway obstruction, compensated shock, a closed head injury with normal airway breathing, multisystem trauma, an inability to treat on scene due to safety problems, and that can be, gangs of people. It can be, structural with buildings and things like that. It can be the likes of weather, equipment failure, or procedure failure. So, secondary survey pediatric, here it is here. And again, it's a pretty straightforward algorithm. There isn't anything kind of funky in it. We have the normal age ranges, we have the estimated weights, we have use age appropriate language for the patient, which is really, really important. Secondary survey 2017 to 2021. So again, the differences in some of the language with regards to child protection concerns, if they're present. Again, it's really just reporting findings to the ED. The language is a little bit different, but nothing major. It's a pretty straight algorithm. Make appropriate contact with the patient or guardian if possible. So, this is your secondary survey from your primary survey. So we're always looking for consent. Identify presenting complaint. Let's have a look. History taken. It's your standard sample history, guys. We're not going to go kind of into this again. The only big thing here is we need to have consent. Sample history is what sample history is. Secondary assessment. If we can identify the patient's weight, it can be intrinsic into helping them out, particularly if ALS are on the way, because a lot of the medications are weight-based per kilo. So medication doses for under 15s are calculated on a weight basis. Chlorphenamine less than a year is 0.25 milligrams per kilo. Ibuprofen 10 milligrams per kilo PO, and again, this is going to be discussed in your pharmacology. Head to toe examination, so expose only as needed and respect modesty. So sick or not sick can be completed en route if deemed necessary to immediate transport patients. So we don't need to wait around on scene. If it's an immediate transport, then we're going to transport, and we can do this stuff on the run. Okay. Sample history, identify the patient's weight, head to toe examination or toe to head depending on the age. Recheck vitals and check for current meds. There's nothing new in this. Age appropriate assessment techniques. So assessment of an infant less than 2 months. So they have a limited behavioural repertoire, and what that means is they have very brief waking periods. They do not make eye contact or track faces. They're in their own little world. There's no social smile. They don't recognise caregivers or parents versus strangers. Caregivers assessment should be considered because they know the child and they know if the child is off baseline. So transport is going to be based on age and history. If we move them up a little bit, things change. So your 2 to 6 month old, so they have a social smile, so they smile, they smile when they see new things, when they see people. They recognise caregivers, they track light and faces, so you can have shiny stuff and they'll follow it around. And we can use this to our advantage when it comes to actually assessing patients. They have a strong cry, increase in vocalisation, they'll sit with support. So examine them in any location using a soothing voice. We can offer them distractions, a set of keys, something glittery while we're doing our assessment, and it works quite well. The 6 to 12 months olds are a little bit different. They do not like to be separated from their caregivers, so we can anticipate caregiver separation anxiety. They're not really as easily distracted, particularly if they're not feeling well. They're socially interactive. They play with toys, they put stuff in their mouth. They sit or squat, and they start to kind of trot around on the floor, so we need to be careful. 1 to 3, normal appearance. The terrible 2s last from 1 to 3 and are characterised by lots of mobility, so they wreck the house. So if you see a 1 to 3 year old who's sitting there, flaccid, not moving, then their appearance is definitely altered. It's important to understand. So stranger anxiety, separation anxiety, egocentrism. So it's all about them. It's all about them. Toddlers are concrete thinkers, yeah. They problem solve by trial and error, which means they fall and they hurt themselves. This is when they learn. This is the big kind of age where they learn about catching their fingers in doors and stuff like this. Assessment techniques. So normally we'll observe them from across the room with the PAT walking in. Allow the child to remain on the caregiver's lap and get down to their level. Use play and distraction. So we examine these from toe to head, because what we're doing is we're not coming centrally into their world. We're starting at their toes, and by the time they're kind of used to us, we're into the business area of having a look at their core. Okay? We enlist the caregiver's assistance if needed. 4 to 10 year olds, normal appearance, mobile, independent thinking. They can talk to you, they can tell you what's wrong. They can be cooperative with exams, but they can be upset. maybe as well. You need to respect their modesty. They misinterpret information unless you're very clear on what you're saying. And independence may crumble when they're sick. So the big hard exterior may actually crumble very easily. Assessment techniques, so examine from head to toe, respect their modesty, minimising time lag, just get it done. Start in the head, move on down to the chest, the abdo, and just do it quickly. If talking fails, restrain to ensure the patient and provider safety, and you can have the parent or caregiver do that if you need to. Adolescent development, so they're very mobile, risk taking, they're absolutely titanium. They're not swayed by common sense. Adolescents have a capacity for rational thought and analysis. Dependence shifts from family to peers, so no longer do they look at mum and dad, they're more interested in their friends and what they have to say. They may misperceive the severity of illness or injury, so they may underestimate it, and that's important. Techniques in assessment of an adolescent, so listen to them, talk to them directly. Don't talk over them or at them. Talk to them and explain stuff. Respect their privacy and confidentiality unless it's something that needs to be discussed with parents. Reassure them and do not succumb to provocation because they can wind you up. It's what they're good at. Children have very different developmental milestones and age-specific emotional physiology. Absolutely. Knowledge of these differences is important when assessing and treating a sick child because if we don't know what's normal, then we don't know what's abnormal. A standardised approach to every child includes the PAT for assessment. The sick, not sick call is the bottom line for subsequent treatment and transport decisions, and you should know this pretty quickly using the PAT from the door. There's a couple of references there, and we will do some scenarios in class.